Right. Okay, so this is a vast topic which I'll try to do justice. And basically, there are, as you all know, there are a lot of factors which influence the outcomes of any IT fracture. So there are three important factors which are under the surgeon's control, which we can actually control, other than the other patient unmodifiable factors. These are the three important factors, out of which I want to touch upon the choice of implant, and the other two things, the quality of the reduction and the positioning of the implants. These are absolutely mandatory. So the point number 2 and point number 3 have to be done properly to make sure that we give a good outcome to all of our fractures. So I just want to touch upon a few basics about how to assess stability of IT fractures, pros and cons, characteristics, if you might, of the DHS and the cephalomedullary nailing. It is an evolving field with a lot of companies coming in with implant modifications as we speak. So it's hard to catch up with the literature. There is a lot of variation in the literature, but we'll try to touch upon all these topics. So the most important thing is to assess the stability of the fracture. So as Dr. Sampson already covered, we have to check the posteromedial cortex, which has to be intact. It should basically resist any medial compression after we get the fracture reduced. Unstable fractures are ones in which the fracture will collapse into varus or it might displace medially. The key is the lesser trochanter fragment. The other, as per the Evans classification, there are other characteristics: reverse obliquity, transtrochanteric, and with subtrochanteric extension. Another important point which will help in our decision making is the lateral wall of the greater tuberosity, the greater trochanter. So if you look at So integrity of the lateral wall of the of the GT is an important factor which will help in our decision making. So there are studies which show that the GT thickness, if it is more than 20.5 millimeter, that is, this is the innominate tubercle. You take a measurement starting 3 centimeters distal to that and extending 135 degrees caudally towards the fracture plane. So if this bit of the GT is more than 20.5 millimeters, then a DHS can be used. If the GT is comminuted or if it is less than that, then there is likelihood that the DHS can fail. So I'm not here advocating any type of implant. I'm a fan of DHS, but recently I'm using more and more of cephalomedullary nailings, but we're just looking at the evidence. So the DHS, it allows dynamic interfragmentary compression, as you all know. The hip abductors are preserved during the approach, and as it is conventional, surgeons are very familiar with it, and it is low cost also. The so-called disadvantages of the DHS are the most important thing is the risk of failure of this construct in an unstable fracture. So if there is an excessive fracture collapse, there can be limb shortening, there can be medialization of the shaft. Lateral wall fractures are especially prone to this complication. And there is always a risk of screw cutout in osteoporotic bone. Another particular characteristics of the DHS is that in the left-sided hip fractures, left-sided IT fractures, as we are tightening the screw, as we are positioning it, there can always be derotation causing malalignment of the fracture. And since it's an open procedure, there is a theoretical risk of increased blood loss also. The key factors here while doing a DHS, which we have to absolutely respect, is the tip apex distance as described by Baumgartner. I'm sure all of you are aware. I'm not going to get into the details, but that is the key determinant in which fractures fail. If the tip apex distance is more than 25 millimeters, then there is a high likelihood of failure of the DHS. The evidence also suggests that the number of holes in the shaft doesn't make a difference. 4-hole plates and 2-hole plates give similar outcomes in stable fractures. Coming to cephalomedullary nails, The advantages that are there are biomechanical, in which it is an intramedullary device, it acts as a strut, therefore the cantilever effect, the moment arm, that is the distance between the head of the femur where the joint reaction forces act and the implant are lesser than the extramedullary DHS. It is a load sharing device, and the intramedullary buttress here prevents medialization of the shaft. It can be done usually as a closed procedure, therefore limited blood loss. It definitely has a learning curve when we come to it. It is technically more challenging, lots of exposure to C-arm. The risk of varus deformity is also there in cephalomedullary nails, but only if the entry point is comminuted. So when you're putting the nail inside, there can be displacement of the fracture site and the head and neck into varus, which is a problem. There is a risk of periprosthetic fractures also. There is violation of the hip abductors. In one study, in one cadaver study, they found that the GT had to be, the gluteus maximus, around 15 to 50% of the gluteus maximus had to be, was violated during the entry of the cephalomedullary nail. And of course, it is more costly as compared to the DHS. Now coming to the considerations, whether to put a short nail or a long cephalomedullary nail, that is number one. So there are distinct advantages of the short nail. It is easy to insert, the surgical time is less, there is less blood loss and lower cost. The long cephalomedullary nail, it protects the entire femur. The logic behind it is that it prevents peri-implant fractures because the entire femur is covered. But the disadvantage of the long nail is that if there is mismatch of the bowing of the femoral bow and the implant bow, there can be anterior impingement or penetration of the cortex. To prevent that, the implant companies have matched the radius of curvature to our population, and also as surgeons we need to make sure that the entry point is slightly more posterior on the GT. The disadvantage of increased surgical time and blood loss is there, and increased exposure to C-arm is also there. In a landmark study in 2016 by Koval and Zuckerman, they found out that the similar outcomes are there in both short and long cephalomedullary nails. The incidence of peri-implant fractures is comparable in both, which is around 1 to 3% in both, and similar cutout and cut-through rates are also there. The long cephalomedullary nail, the long cephalomedullary nail is especially indicated in subtrochanteric fractures. The next area of controversy is in cephalomedullary nails, whether to use a single or a double lag screw. So again, there are different types of lag screws. Some of them slide through the nail, some of them are constrained. But overall, the single lag screw we are more familiar with. It is similar to the DHS. It is easier to do, faster to do, and but there is rotational instability as with the DHS, which can cause failures also.
Sir, we are sorry to disturb.
Running short of time? Yeah. Okay, let me just quickly finish. The double lag screw, as I said, can slide, but it gives better rotational control. The Z effect is known to happen with this, and the outcomes of both are equal to each other. Lag screw versus helical blade. The helical blade is a more recent advancement. In one study, they found that the amount of bone loss is quite less. In a cadaver study, they found that 30% increase in local bone density was found because of the impaction of the blade. It gives rotational control, higher cutout resistance, but is more prone to cut through. That is, the blade can go in and penetrate centrally, whereas the lag screw can cut out cranially. But similar functional outcomes with the available literature. Whether to lock distally or not, in stable fractures, no difference, but in unstable fractures, it is definitely recommended. So take home message, assess the stability, which is important in selecting your implant. In stable fractures, either a DHS or a cephalomedullary nail, both will do the same thing. Unstable fractures, definitely cephalomedullary nailing has better outcomes. Please do not forget to take into factor the pre-op reduction of the fracture and positioning of the implants.